For all those joining, welcome. This is Christine Toriuson from FHI 360. We're going to give a few minutes for participants to join the PrEP, the PrEP Learning Network target setting session. We do have all attendee lines muted at the moment, but we do have the chat function. So if you're having trouble hearing, you can let us know that way. I see we have a good morning message from Jason. Good morning back to you. So we're at 1 minute after the hour, but we're just going to wait another minute or two. Greetings, everyone, and you'll note that on the chat panel there is an option of sending a message to all panelists and attendees. That's the best option if you want everyone to see your chat. Okay, so I think we'll get going. It's 2 minutes after the hour. This is Christine Toriuson from FHI 360 and the Options Consortium, and welcome to today's episode of the PrEP Learning Network webinar series that is hosted by Options, EPIC, and RISE. Today we're going to focus on target setting for PrEP. Martha, you can show the next slide. So this is an overview of the session today. We will talk through the PrEPIC tool as well as a UNAIDS target setting tool and share some examples of how these have been used in country. Next slide, please. Our speakers today are Catherine Kripke from Avenir Health, Nicole Bellows from Avenir Health, Cindy Matze from the National AIDS Program in Eswatini, Keith Sabin from UNAIDS, and John Stover from Avenir Health. So as I mentioned earlier, there is a chat function. We do have all participant lines muted in order to keep the line clear for our speakers. However, we do welcome questions, comments, additions, other thoughts that you have being shared via the chat. And as you'll see when you go in the chat there, it might say all participants, but mine says all panelists and attendees, and that's the best one to send a chat through. We will be answering questions at varying points and responding at varying points throughout the webinar. So if you have anything on your mind, or you want to ask a question, or you want to add a comment, please go ahead and use the chat. Next slide. Okay, we're going to launch with our overview of target setting considerations, and I'm going to pass this over to Catherine Kripke.
Hi, everyone. I just wanted to frame the conversation with a brief overview of target setting. Please advance the slide. So we're thinking about targets in terms of why do we set targets? We set targets because we want to see if an intervention that we're setting targets for is going to have an epidemiological impact. So ideally, we want to be serving enough people to have an impact. And the way that we have an impact is by getting enough coverage of the populations that are at risk for HIV. And once we have the targets, these are used for planning and budgeting, estimating the funds, the number of ARVs, the staff, labs, and other resources that are needed. Next slide. Thank you. So we can think about target setting generally in two different types of approaches. One is based on coverage, and that is for the purpose of the epidemiological impact, as I mentioned on the previous slide. So you can think about this as a top-down approach to target setting, where you set targets based on the coverage levels of each priority population that you're providing PrEP to. Another way of creating targets has to do with your capacity to deliver services. So if your capacity is particularly limited and you're not going to be able to reach epidemiological levels of coverage of your priority populations, you might set targets based on capacity. And we think about this as being a bottom-up approach to delivering targets. Next slide. So there are a number of challenges for target setting, especially for PrEP. One is identifying the populations that should be prioritized for PrEP. There can be a number of considerations for this, including epidemiological impact, equity, and feasibility, and other considerations. Once the populations are selected, then it can sometimes be difficult to know the size of the priority population. So if you're trying to set your targets based on coverage, you need to know how big your population is to know what your coverage is going to be. Another challenge is knowing what percentage of each of your priority populations might be indicated for PrEP, so might be considered to be at high risk or have some other indication for PrEP. In addition, with PrEP, people don't always stay on PrEP once they start, and this can affect the coverage of your population. So it's important to take into account the continuation rates and not just initiations when we are thinking about PrEP and the impact of PrEP. Another challenge is that sometimes people cycle on and off of PrEP as they go through different periods of risk. And so that can make it even more challenging to estimate your coverage. Finally, there may be needs in terms of achieving coverage of a population, but matching those needs to the resources available can be a challenge. And finally, understanding which targets are feasible given the funds as well as the demand. So that's all I have to say for setting the stage, and I'll pass it on to my colleague, Nicole Bellows, to give an introduction to target setting within PrEP-IT.
Thank you, Catherine. So I'm going to just briefly go over some of these concepts that Catherine's talked about with regards to PrEP-IT, the tool that we launched in September to assist with target setting as well as other utilities. Next slide. So for those who might not be familiar, PrEP-IT stands for PrEP Implementation, Planning, Monitoring, and Evaluation Tool. This was funded by USAID through the HP Plus, Options, and ETAP2 projects. It's an Excel-based tool that supports governments, donors, implementers, and other stakeholders on oral PrEP program planning and M&E. And there are 6 interrelated modules. So today we're focused on target setting, and we'll explore that module in the tool itself. But there's also relevance because these are connected to the other modules. So once you've set your targets, you could then look at, what are your ARV needs to meet them? What is your estimated impact? What will the costs be? Do you have the capacity to achieve these targets? And then, tracking the delivery of PrEP against those targets over time. So there's a lot of functionality in PrEP, but we see it as having 2 primary purposes. There's the program planning, mostly for government donors, and this is where target setting is often focused. And then there's the PrEP implementers who want to look at more of the M&E functions around projecting client flow, assessing capacity, et cetera. And of course, there's overlapping needs as well. One important point we like to emphasize is that with all this different functionality going on, people don't have to use the entire tool, but they can just focus on the aspects most suitable to their needs. Next slide. So I just wanted to put in where you can find PrEP-IT if you're interested. It's located on PrEP Watch. And in addition to the tool itself, there are also a user guide and instructional YouTube videos. Unfortunately, I can't, we don't have time to really do a how-to in terms of using the tool. We're gonna talk about the various steps more conceptually, but that guidance can all be found here. And last slide here. I just wanted to set up an example scenario for somebody who would be approaching PrEP. This is a country that's been providing PrEP to a number of populations in a subset of their districts. And now they're going to be setting targets for the next 3 years and adding on additional populations around AGYW. That in addition to setting targets, they want to disaggregate them. And then they also want to take this top-down coverage approach that Catherine mentioned, where they look at the number of potential users and think about what proportion want to be covered on PrEP. So that's sort of to set the landscape before we get into the tool itself. So now I'm going to try to share. Okay. So hopefully people can see my screen. And here I am on PrEP. This is on the Getting Started page. Just quickly, a brief overview to orient yourself. The color key shows you where the inputs are. So these light orange or light yellow indicates a drop-down list, and the darker orange is where you need to input numbers or text. Other colors indicate reference data or where you've made some selections. So this page is really just to, again, review all the different functionality in PrEP and direct you to the appropriate inputs. So as we mentioned, we're going to set targets based on coverage, and we're going to disaggregate those targets. So hopefully you could then see on the navigation bar that certain input steps lit up, and this is how you can navigate through the tool. So our first step is looking at populations. And Catherine talked about how this is typically done in the early stages of program planning and how one wants to, who they want to provide PrEP to. And at least one priority population has to be specified in this case. If you're providing PrEP and you don't want to specify by priority populations, you can just choose a custom group focused on all users, if that's how one's approaching it. But typically, people like to look at different priority populations because there are differences in terms of the population sizes as well as percent indicated for PrEP, et cetera. So we have a list of commonly selected priority populations here, but as I mentioned before, you can also specify custom groups if the population is not on your particular, on this list. So once you've specified your priority populations, these sort of populate throughout the rest of the tool, and you can think about the continuation rates. Catherine mentioned the importance of continuation rates for understanding how long people stay on PrEP, to understanding how many are on PrEP at a given point in time. So we ask people to put in for at least one continuation curve, which is 4 data points, but there's room for up to 6 different curves. And so the data we're asking for is for your priority population after initiation, what proportion are still taking PrEP after month 1, 3, 6, and 12. And this often varies by priority population. So you can see we've put in data here where the serodiscordant couples tend to stay on PrEP longer compared to other populations, such as like different key populations and AGYW. Of course, this varies by program and by country. This information here is just hypothetical, but we did base it on some reference data that was available that you can see from empirical studies on different continuation rates. We know that some people have this information in their M&E systems, and some will have to make estimates, which is why we provide this reference table as well as an additional tool that one can calculate, estimate from a sample of their patient records. So we'll move on to the next step is targets. So once we get to the target setting page now, this is where most of our work is done, is target setting. And after setting the target setting period, we need to think about what are our number of potential users. And as Catherine mentioned, we need to consider the population size. If you're only providing PrEP to a subset of the geographic area, what proportion of the population is in that designated area. To think about HIV prevalence, and then this idea of the percent indicated for PrEP. And we recognize that these are not easy data points to fill in. So we have provided some support where we bring together some data sources to help provide estimates if they're needed. So we provide some default estimates here, and we tell you kind of where the source came from, et cetera. Our understanding and hope is that a lot of countries have better data than that we were able to pull together sort of at the global level. But we just wanted to make sure people knew this was available if they're having difficulties, knowing where to start with some of these inputs. In terms of the percent indicated for PrEP, I believe Keith is going to talk about that, and that's a really interesting area. But that's, the percent who are most at high risk for HIV typically, or other different eligibility criteria. So putting in all these factors, then we can calculate the number of potential users who are going to be HIV negative, indicated for PrEP in the geographic areas of interest. Moving down, our continuation curves that we've just specified have been brought over. And now we can think about scale-up trends. This is how we plan to roll out our targets over the target setting period. We have 3 different shapes one can choose from. There's constant. This is for a program that's already at scale and expecting a same number of initiations each month. Linear would be more of a continual scale up, increasing each month. And then there's the most common, the S-shaped curve, where you start small with your program and then reach a rapid scale up before leveling out to the point where you're scaled up. So you can choose between these different shapes, and you can also manipulate the S-shaped curve. But this is really something to discuss in terms of the planning on how you, and a lot of it depends on where you are in your program. So when I applied these scale-up trends to my priority populations, in a hypothetical scenario, we've been providing PrEP to these first 3 populations for a year. So we applied the constant, assuming that we're already scaled up and it won't be increasing during our target setting period. In contrast with the newer AGYW program, we applied this S-shaped curve to. So next we select our target setting option, and in PrEP there are 3 options. There's coverage, the one we're going to start with, capacity, and then what we call the manual or direct input. So we're starting with option 1, which is setting targets based on the percent of potential users in each priority population who will be taking PrEP at the end of the target setting period. So this isn't how many people are going to, what percent of the priority population or the potential users who will try PrEP throughout that period, but what proportion do we want to be on PrEP once we get to the end of that target setting period? So once we've scaled up, what proportion do we expect to be on PrEP? And what is a realistic expectation of this? It just depends a lot on the priority population, as well as the specific program. And also, the continuation rates are an important part of this, because the longer one stays on PrEP, the higher that percentage can be. So I've put in some starting numbers here, where I'm saying 30% for ST6.
Okay.
Oh, sorry. All right, I'll continue. And then using this function. If somebody could mute, that would be preferable. But we can run the solver where it calculates the appropriate number of initiations for targets. So I'll just change these So you can see once you make changes, the targets down below light up in yellow. And then when you run the solver, it says, given the number of potential users we have, the continuation rates, or how long people stay on PrEP, the scale up pattern that we've selected, how many initiations do I need during my target setting period in order to reach this coverage level at the end of the target setting period. And then that gives us our number of initiations by population. Option 2 is looking at capacity. And for this, you'd have to fill out the capacity tab in PrEP that's geared towards estimating what your monthly total capacity is for initiations. So we won't go into that. Again, you can kind of look online if that's something you're interested in. But often what people might want to do is, okay, I've set my targets based on coverage. Now I want to make sure that those are achievable given what I know about my capacity. So here, conveniently enough, they're comparable. But that, this shows you your total annual capacity. And then what you need to do is allocate your capacity across your priority populations. So I'm a bit too high here because this should sum to 1 when we're talking about capacity. So that's just a way of sort of verifying that you can reach these targets that you've set. A third option then is manual entry. This is different than setting targets, but more suited towards an implementing partner or a country that's already established their targets and that it can just enter them in here. So while this isn't target setting per se, it's entering in your targets that then can link to the other modules of the tool. So you can enter in your targets and see how they compare to your capacity, to think about the costs, as well as other features, and also look at your coverage based on the targets that you entered. So I'm going to go back to my original targets. Rerun them. Great. And so now what we can do is we can also disaggregate targets. This is a feature, again, if you were an implementing partner or just a country that now that you've set your targets for 3 years, you want to look at them by year and you want to disaggregate them down to the district level. You can do that here. So you can set the subset of your target setting period that you're interested in disaggregating. And then you choose the appropriate age, sex groups that you want for disaggregation. So here you can see I've chosen everyone for STCs, the female groups for FSWs, male for MSM, and then just the select age groups for females for AGYW. You also then enter in for each district the population for those over 15 years old. And then once you've done this, we can take these targets and we can disaggregate them to the district level. An additional feature that's specifically for PEPFAR is that this can also then generate these district age sex targets that can be used for country operational plans. This is based on the most recent version of the data pack. I'm not sure to what extent that's changing, but right now it's set up to be kind of a copy paste into the data pack. So that's another application where if you already have your targets, but maybe you want to enter them in for this particular functionality. So that is the general overview. I will stop there and let's see, and now I'm going to pass it off to Cindy to discuss using this tool in Eswatini.
I'm not sure if Cindy is actually connected.
Catherine, do you think you could speak to her experience since you were at that workshop?
Let me see. Yeah, Cindy, are you there?
Yes, I'm at the moment, but the internet is unstable, so it can.
Why don't you give it a try? And if it doesn't, if it doesn't work, I'll try to. If it doesn't work, I'll try and present your slides. Go ahead and start.
Okay. Okay, thank you. Okay, thank you. May I start with some background for Eswatini, which is a small country that is situated in the southern part of Africa. We have an HIV prevalence Hello? Hello?
Yes, you were breaking up, but I can hear you now.
Okay. So I was saying we then considered to add PrEP as part of the HIV prevention package and started with implementing demonstration projects in 2017 and were led by 3 partners. There is CHI, FHI 360 linkages and MSF, and it was coordinated by Ministry of Health. We just approved in 2018 and included the demos in 20 January. So as part of the scale-up, we have identified priority population based on our HIV incidence rate, and young women, also high-risk men, 30 to 34 years. And we wanted to set target as part of the scale-up. Unfortunately, it was very difficult if you consider the dynamics of PrEP. In June 2019, as a country, we're supported by USAID to conduct a PrEP workshop, and it was conducted by Options. And then we used this opportunity to set the national and regional targets and further disaggregate by the subpopulations which are prioritized by the country. So may I have the next slide? So in setting our targets, our experience been that there's 2. It does not automatically set the targets. However, it provides a useful for discussing the desired approach that we can use as a country also to come up with key assumptions. It also provides a visual way to show the impact of decision as it relates to the target setting. And as we were setting the target, we chose the option 1, which is the coverage approach. It's a top-down approach, as it has been alluded to. It takes into consideration the desired coverage of the specific subpopulations that are targeted, the site capacity, and the number of sites to offer the PrEP in the country. In terms of our priority populations, as it has alluded, it is very important to know your population size estimate so that you can also feed into this. So what was also important, it was to provide HIV prevalence for these different subpopulations and also come up with I must say that it was not easy for us to come up with dedicated for PrEP. And also to highlight, it was that way we didn't have data on the previous sources from global studies that have been conducted. So for those percentages, we use some default values to start the discussions, and then we consider all the dynamics of the different groups. We're also able to visualize the different continuation curves for both the general population and the population based on the data that we had from the demonstration projects. And it was also helpful in understanding the consequences of changes in the continuation rate. So we're able to play around with different continuation rates to see what is happening within these populations. scaling up, another thing that we've adopted from this tool is and integrated is the program data tab into our M&E system that will help us to track the implementation of PrEP in the country, and we are able to visualize our PrEP cascade. For the coverage, I think the experience from the demonstration projects and the goals were very helpful in helping us to come up with setting this target and using the approach that we ended up choosing. I think that's that we have as a country.
Thank you, Cindy.
So I think this is where we have opened the floor for questions. I've seen a couple of different questions in the chat box. One recent one was, if you don't have a lot of data, can you still use this tool? And the answer is yes, that the amount of data that one needs for target setting in particular, you need to have some estimate around your population size and prevalence and risk. But these can be estimates, and we recognize the challenges and sometimes even just getting this information together. But that is why we try to develop the target setting support tab if you're a country listed on that drop-down list on the first getting started page. Additionally, for the continuation rates, we recognize that this is often challenging and that one needs to make estimates. But we start somewhere and we hope for better data as we move forward.
Nicole, there's a few questions that I think we can perhaps address during the Q&A. One is how to estimate the % indicated for PrEP. Maybe I'll start with that and then you can jump in.
Sure.
So target setting, I should start by saying, is a little bit more of an art than a science when it comes to PrEP, because there are going to be pieces of information that you'll be missing. You might be missing the size of your priority population. You might be missing estimates of what percentage are at risk. So if you don't actually know for a given priority population what % is at risk or would be indicated for PrEP, you can make an estimate based on your knowledge of the situation in your country. Another way of looking at it is to, if you have program data, you could potentially use your data from screening. So of the percentage of people who are screened, what % are eligible according to whatever your country criteria are for that population. That's one way that you could look at it. But there's not necessarily going to be a concrete formula for % indicated for PrEP for every population. It's going to have to be a conversation among the stakeholders in country in a lot of cases. Nicole, did you have anything to add?
I think this is a really rich discussion, and I know that Keith's presentation coming up goes a lot into an approach used as well. So maybe we can kind of convene and regroup and after his presentation for further discussion on this.
Okay, so we have a couple of other questions that perhaps we can address, and it looks like we have time. So another one was, how do you estimate or map the potential PrEP users? I think that's similar to the previous answer, which is that it depends on who your priority populations are. It depends on your size estimates. It depends on where they are in your country, and it depends on what your criteria are for PrEP eligibility. So there's not one hard and fast answer. And then that also goes to another question about the % eligible for PrEP based on geographic area. So if in your country you're providing PrEP to everyone, regardless of where they live, then it's going within PrEP, that number is going to be 100%. However, if you're only providing PrEP in certain districts or counties or provinces or regions of the country, then you would estimate what percentage of the total population is living in those areas, and then put that percentage in it there in PrEP-IT.
Yeah, and just to further detail on that, in the example that we just looked at, you might have a subset of your country that has, 25% of the population, but then for certain subpopulations, it has much more. So maybe it's 25% of the general population, and for your AGYW, but then it has more like 50% for your, female sex workers or men who have sex with men. So understanding kind of the dynamics of where your priority populations are located can be useful for doing your best to estimate those population sizes.
Yeah, I mean, the reason why we put that that parameter in the target setting tool is because in some countries they're only providing PrEP in certain districts or certain counties, and so to enable the target setting exercise to take that into account. But if that's not relevant, you can just put 100%. And then the last question I think that we should address is what is a desirable or optimal continuation rate? That's a really interesting question. I think the answer is not quantitative. Again, it's a little bit more of an art than a science, because you really want people to be taking PrEP when they're at risk. So if people are moving in and out of seasons of risk, then they don't need to continue taking PrEP. So the way that you would know the optimal continuation rate is to know more about people's patterns of going in and out of risk. So that requires additional research. I mean, ideally, we want people to continue on PrEP for as long as they're at risk, and research has shown that there are a lot of reasons why people discontinue. They might discontinue because of stigma, they might discontinue because of side effects, and we would like them not to discontinue for those reasons if they're still at risk. But if they discontinue because they started using a different prevention intervention that works better for them, or because their situation has changed and they're no longer at risk, then that's okay. So I think ideally we want the continuation rates to be higher than what a lot of the programs have seen. But then exactly how high, it's hard to say. And I don't know if we're going to be having another webinar about continuation. Are we, Martha, Christine?
We actually already had a webinar on continuation, and resources from that can be found on the Learning Network site.
And we are planning a follow-up webinar in Q1 of 2020.
Okay, so please, I hope you'll access the recording from the prior webinar and join the webinar that's coming up in January, because this is a very rich and interesting discussion. Were there any other questions that we should address before moving on?
A question has just recently come in asking, how long has this tool been in use? And what have we learned about it with helping teams set targets? Is there any feedback, or is it too soon? To speak to that initially, and then Catherine, you can jump in as well. This is the creation of PrEP. It's been a year-long process. We started last October, and it was piloted in, we got a lot of information from both Eswatini and Mozambique initially to help start with the design phase, and then we piloted it in those countries as well as in Kenya and Zimbabwe. Sorry, Zimbabwe was one of our initial countries as well. And so we got a lot of really great feedback from them in terms of its utility, and that was, and that's a big part of what you see with the tool itself. In terms of setting targets, I mean, we heard Cindy's experience, but we just released the tool in September, so it is a bit soon in terms of getting a lot of additional feedback on the use. But we're anticipating people using it for this, upcoming in the next few months, and we're eager to get feedback on how it's working for people. Do you have anything to add, Catherine?
Yeah, I mean, the process in Eswatini was really instructive for us. I think one of the things that we saw was that the process of target setting was iterative. So the team, you know, set some initial targets and then looked at them and decided that they weren't really very realistic. And so they modified their coverage rates based on what they thought might be more achievable, and the available budget and things like that. So, you know, the target setting module within PrEP, we think of it as less like a formula and more like a framework for a conversation among the country stakeholders. And so, and the approach in a way is quite simple, and it's consistent with the ways that other groups have approached target setting. So it's not like it's rocket science, but it does provide a good structure for a conversation. And then the other thing, Malawi has also used the country has used the tool for target setting successfully. We haven't gotten as much feedback from them because we weren't there during the exercise, but they did use it for setting their national targets, and several other countries have expressed interest. So as you use the tool for target setting or anything else, our team is very interested in finding out what's working, what's not working, what questions you have, and I hope that people will keep in communication with our team.
Great. So I think next on the agenda is to hand it over to Keith, who's going to share his tool for target setting. And something that I briefly alluded to was that this tool is really complementary to PrEP, in that it talks a lot about how to get to that percent indicated for PrEP, among other things. But I think that this will be a great kind of follow on in terms of the discussion as we continue.
So good morning and afternoon to everybody. While it's my name on the slide, I really have to credit Jerry Jacobson, who did most of the work on this. Do I have control of the slides?
No, I do, and just
that's fine. Okay, next slide.
I didn't anticipate you, but
that's fine. That's fine. So next slide, please. So as Catherine mentioned, this was born out really with the idea in mind of creating targets at a fairly local level and relying on local risk data. So we wanted to come up with a pretty straightforward method that countries can use to estimate the number of individuals at quote unquote substantial risk of acquiring HIV. And initially we were focused on what we consider the, I guess the classical key populations. So men who have sex with men, trans women, female sex workers primarily, but also male sex workers and people who inject drugs. We've begun to develop a module on adolescent girls and young women. It was based on DHS data, and we are just acquiring the FIA data to see if we can't make something a little more attuned to the greater quantities of data in the FIAs. So next slide, please. So really what we're going to focus on is those at the greatest need, which are coming up with the people, the number of people at substantial risk of acquiring HIV, assuming that those are the people in greatest need of PrEP in order to prevent contracting HIV. Next slide, please. So the presumption is that the target in the current slide will be the red dot, the high-risk individuals, and that the PrEP users, current PrEP users, will be somewhere inclusive of that group of people, and there may be some low-risk people who choose to use PrEP for whatever reasons. But the idea is to be able to offer PrEP and not necessarily stigmatize those people who perceive themselves at risk or who might be perceived at risk by the public health community and practitioners. Next slide, please. And just to be clear, the focus of this effort is on the large rose-colored circle at the outer edge. We're looking for those people who are at risk. We're not going to talk about cost effectiveness. We don't address that with this little tool, nor do we concern ourselves with demand. We're really looking to see who is at risk and who would benefit, and what should the program target be for that group. So next slide, please. So the guideline, which unfortunately is not on the UNAIDS website yet because of a number of factors, not least of which is it's 98% completed, but until we get that last 2%, we're not allowed to put it up. But we can make it available to people through other means. But what's in the guideline is basically a framework for calculating the number of people at substantial risk, some guidance and considerations on data sources that may or may not be available, and some common adjustments which can be done within the tools that are provided. Resources are there to develop risk criteria if you want to set risk criteria for your local context. There are examples and there are spreadsheet tools, again in Excel, so fairly accessible. It's nothing proprietary. And then we have some sensitivity analysis available to suggest that the methods matter. That is, the way the data are collected and the way that they are utilized in this tool can make a difference in your ultimate targets that they would be calculated. Next slide, please. As I mentioned earlier, what is not in the guideline, it is not a cost effectiveness tool. It does not set guidance for clinical screening, nor is there any guidance on scaling up. And that's where you may want to use PrEP instead. So next slide, please. So it's a very simple formulation in this tool. We start with a population size estimate. And next slide. We calculate the proportion of people who are at risk for acquiring HIV infection. Next slide. And that gives us the number of people at risk. The math is simple enough. The trick is in having these data available. So next slide. So we attempt to find the best HIV prevalence estimate that might be available. And we utilize that. And then we start with the proportion of people who are HIV negative in that population. So if this pie chart reflected female sex workers and they had a 20% HIV positive rate, we'd be interested in the 80% who remain HIV negative. Next slide. And we would want to understand what are the risk behaviors among those people who remain HIV negative. If you have an individual who is using condoms 100% of her sexual encounters, she may not be at substantial risk. So we would want to understand what remains. And so we have to ask the question, what qualifies as substantial risk? And in this slide, we just list some examples for a consideration around men who have sex with men. And we ask, would it refer to any sexual activity? Would it be greater than one recent partner, recent being locally defined? Would it be any recent unprotected anal intercourse? And so on. So these are some of the risks that we might want to examine. And next slide. And what we did was we used data that were available primarily from biobehavioral surveys to estimate odds ratios or relative risks, and then we pooled those estimates in order to see what were the behaviors most closely linked with incident HIV, where incident HIV data were available, or more commonly with prevalent HIV, because that's typically what's available. And we wanted to use those data to see which of the behaviors with the highest risk for HIV infection exist among those people who remain HIV negative. And we just presume those are the people with the greatest or the substantial risk. So looking at this particular table, you might look down and say, number of male partners has a fairly high risk, a pooled odds ratio of 3. When looking at incidence, looking at anal sex, the odds ratio is also 3, unprotected anal intercourse, also 3, etc. So we would want to take the proportion of men who report these behaviors among those men who remain HIV negative. So next slide, please. Next slide, risk factor approach. So in considering the risk factors based on local evidence, we might end up looking at whether they had a recent sexually transmitted infection, whether we had the number of partners, UAI, unprotected anal intercourse, or recent drug use. And next slide, please. And we consider some of these direct links, and drug use would be an indirect link to HIV acquisition. In this case, we're not talking about injection drug use, but rather something like chemsex. Next slide, please. And then we might consider these different risk factors and put them in order of what we consider to be the highest risk, medium risk, and low risk, based on the actual measured estimates for each of these. And that could be based, or in this case is based on odds ratios that were found in locally available surveys. Next slide, please. So in this case, if country A were to decide to consider high and medium categories as being at substantial risk, then they would aggregate those two groups, or all the individuals who meet those two sets of criteria. Next slide, please. And this is just what it looks like in a schematic form in terms of what we need for the data and how we would apply it. So we're just taking the population size estimate to the left, PSE. We're multiplying it by a projection factor if needed, and this is all described in the guideline. And then we multiply that size estimate by the proportion of individuals who are found to be HIV negative. And then we might, if we feel that we may have an underestimate or an overestimate based on the available data, we might use an inflation factor or a deflation factor to wait for biases that we are aware of. And then finally, we'll multiply that number times the proportion of people at substantial risk after the analysis of pooled risk behaviors. So next slide, please. So while I think that might sound a little complicated in this set of slides, it's actually fairly easily tracked through the spreadsheet tools that are available. So if we go to the next slide, this is all in one workbook. This is the title slide. Next, please. And so you would set this up, and these are some example slides that have been developed by Jerry. And you would set up your definition so you know which group you're looking at when you open up the slide set. In this case, we're looking at men who have sex with men who are 18 years or older and in Kampala, Uganda. Next slide, please. And fortunately, we have some size estimates that were locally derived, and we have them over time. And so we were able to look at the 2017 size estimates, which are shown here. So about 11,000 men who have sex with men in Kampala is the estimate. There was some projection for population growth, which is line 34 in this case, that's in blue. The proportion of HIV negative, which was established from analysis of the IBBS data that were available to us to just try this example. And then there was a subgroup inflation factor. So you'll note there are notes here that say, that give you an idea of how biased or where the biases might lie. So they're looking at, in general, where do you meet men who have sex, other men who have sex with men? Is it in clubs, bars? And then they use this to determine if this might be an overestimate or an underestimate of the size. And then the proportionate risk among those who are HIV negative is taken again from the IBBS. And unfortunately, I've cut off what that is, whether that's based on. But the final number here is the estimated number at risk is 4,594. So we'd say 4,600 would be the target for Kampala, for men who have sex with men in Kampala. So next slide, please. And all of this would end up in this output box when you're done. So the risk proportions and the estimates. So when it's all finished, this is your final outputs. Next slide, please. And that's where it ends. So I would encourage you to, we'll make these available so you can walk through each of the samples. And I think between the guideline and the worksheets, you can walk through these workbooks fairly easily. It may not be simple to determine the risks among those who are HIV negative, but you might just use regional benchmarks that we've established in the guideline. I wouldn't say established, we've estimated them for a few places, and you can at least start with that if you don't have locally available data. So I'll turn it over there, back to the organizers.
Thanks. This is Catherine again, and I just wanted to mention that what's great is that these two tools are very complementary. So one of the questions that came up about PrEP is how do you know the percent at risk? And so this UNAIDS target setting tool provides a more structure for using an evidence-based approach for determining the percent of a given population that's at risk. And so the percentage that comes out of that could then be entered into PrEP in terms of the percent indicated for PrEP. And then you can use the additional functionality of PrEP that takes into account the continuation rates and the scale-up patterns to determine your numbers that you should be initiating in each month of your target setting period. So I think the two tools could work together in a way that's quite complementary if people wanted to use them in that way. So I'm now going to pass the baton over to John Stover, who's going to give us an overview of the new global targets that are being set for PrEP and how they're, what was the approach for setting that?
Okay, thanks. So I just have one slide. If you could show me the next slide, please. There you go. So as most of you know, in 2016, UNAIDS released its fast track strategy, which included the 90-90-90 treatment targets by 2020, and also included targets for all other prevention activities such as condom promotion and outreach to key populations and PrEP as well. So that's getting a little bit old now, and 2020 is right around the corner. So UNAIDS is in the process of updating that strategy with something they're calling the 2025 target setting activity. And it will, like Fast Track, try to estimate globally what the impact and the cost would be of achieving ambitious targets. So they're not changing any 2020 targets. Some countries will meet them, some countries won't. But this exercise is setting new targets for 2025 and basically keeping the 2030 targets the same. So I'm going to focus on these new 2025 targets and what they say for PrEP. So this new exercise is tries to set targets that are much more differentiated than the old one. So in this table, you can see we have different population groups: female sex workers, men who have sex with men, transgender, etc. And there are different targets for each of these population groups. In addition, the targets are differentiated by the background risk. So you can see columns for high-risk geographies, medium-risk geographies, low-risk geographies. In most cases, you can read geography to mean district. So district or county, whatever the second administrative level is in a country. So the basic idea there, if we look at female sex workers, is that we should have a high coverage of PrEP in places where the background incidence is quite high, and then moderate or low levels where the background incidence is medium or low. Right now, the cutoff values are being used are incidence above 3% to define a high-risk geography, 0.3 to 3% for medium risk, and less than 0.3% for low risk. But actually, if you look at incidence by district, we really don't have many districts at all that are above 3% for either the entire population or the population of adolescent girls and young women. So most of these targets will be drawn from the medium risk category or the low risk category. And in addition, you can see that for the row for adolescent girls and young women and for older adults with multiple partners, there's a further disaggregation between high risk and low risk individuals living in those districts. And this gets exactly to what Keith was just talking about. Where within a particular district, we know that there will always be some adolescent girls and young women that have higher risk than others. So here we've been looking at the proportion that report they have more than one partner in the last year, and the proportion that reported an episode of an STI in the last year as indicators of high risk. So for each country, we will use survey data to determine the proportion of adolescent girls and young women that fit into that high-risk category, the proportion that fit into the low-risk category, and apply these targets appropriately. The last thing I should mention is that there's also a condom target, but the condom target is specified in terms of 90% coverage of either condoms or PrEP, or actually in the full definition, having an HIV partner who is virally suppressed. So there's a recognition here that we just don't need to do everything everywhere, but people will choose different modes as the way to protect themselves. So there's an interaction here between the targets for condoms and for PrEP, as well as for ART. So we haven't finished the analysis yet. This full update strategy is due to be released sometime in the fall of next year. So work is still going on. But initial indications are that using these targets is going to raise the global target for a number of people on PrEP from 3 million, which was the current target, to something considerably higher, perhaps 8 to 9 million. So it's going to be suggesting quite a few more people may be on PrEP. So these are global targets, and they're used for this global targeting exercise. They might be maybe a first draft for what you might do within your country or locally. But as both Keith and Catherine said, these targets ought to be refined to be appropriate for the local epidemic. Thanks, I'll stop there.
Great, John, there was one question about how condom use is taken into account in these. I know that there's a note there at the bottom.
Yeah, just to say that we recognize that we're not suggesting that 90% of people use condoms and 80% use PrEP, so we have 72% or so using both. Now we're suggesting that one or the other method should be used to protect yourself.
Great, thanks. So I think now we're at the Q&A part of the agenda. I've seen a few different questions coming up, and I see multiple are coming in now. One question that came up earlier is, with regards to maybe a good question for Keith in terms of how would you, or is it possible to consider pregnant and breastfeeding women using the tool?
It really is not a question well suited for the tool as we've developed it, because in my mind, their risk is because they're in a serodiscordant couple. And unless we can find the appropriate data for that in terms of how many pregnant and breastfeeding women are in serodiscordant relationships where their male partner is not on virally suppressed, we'd have to figure out what those numbers were like. And at this point, I can't think of where we'd come up with that data.
Okay, great. The person who asked the question mentioned that we did include that as a priority population in PrEP based on people starting to focus on that group. There are some default estimates that could be used looking at some DHS analysis around STIs in the prior year and other factors around condomless sex and multiple partners, et cetera. But this is, a good question in terms of thinking about aspects of high risk. And I think a lot of the data is still coming in and people are still trying to get a good handle on that for that population, although others might be able to speak to this with more knowledge, since this is not a particular area that I'm familiar with. Catherine or anybody else on the panel, do you have any other thoughts with regards to pregnant and breastfeeding women? Okay. Another question that came up was, can we use PrEP? This was during the PrEP presentation if we don't have very much data. And the answer is yes. You don't need a lot of program data in order to use the tool, but you do need to make some estimates around your population size and around your continuation. And you can use, your best estimates moving forward, as we mentioned before with a prior question that was similar to that. I'm reviewing for any other additional questions. Does anybody else? There was, similar to the pregnant and breastfeeding question, there was a question posed around whether or not you could use the various tools for populations besides the ones we've been talking about today in terms of serodiscordant couples and certain key populations. We also have a question around clients of sex workers as well as women with multiple partners. I know in PrEP, this can be used as a custom population where you basically select your custom population and define it yourselves. In that case, you have to come up with these population estimates on your own. The ones that we have in the list that we've created are ones where we could make some good estimates on population size. So I guess the bottom answer is yes, you can use the tool for whatever population you want to. It's just that you have a little bit of help in there for those on the drop down list. but we have examples on the website and in the populated tool that's provided as an example where people create custom populations and fill that information in themselves.
There's another question that just came in, Nicole.
Do we need crude population estimate data, or do we need to use specific model data with mathematical formulas? I can just speak for PrEP-IT. I think for PrEP-IT, you use the best population estimate data that you have available. I don't know, Catherine, you might want to add to that, and Keith as well. But you know, sometimes we don't have the exact numbers that we'd like to have. But we have to start somewhere.
Yeah, I completely agree with that. And it also depends on which population you're talking about. In some of them, you might have modeled data, and in other cases, you might have survey data, you know, or you know, population size estimates based on behavioral surveys. So it really depends on which population you're talking about. But as Nicole said, you use the best information that you can come up with.
Yeah, I would chime in and add that don't wait for the perfect population size estimate because it's not out there. So use what you have available, whether it's modeled or from some other source.
And he's just clarified that he's talking about key populations in particular. Keith, do you have anything else to add to that?
Yeah, if you need size estimates to the degree that they are available, UNAIDS has size estimates both for whatever administrative area they're available. If they're in some form of publication, whether gray literature or peer review, it should be available in our key population atlas. And we're going to revise that and try to make as many of those resources, the actual sources, available for download, not just the numbers. So, you know, if you have a particular setting in mind, you can check there or check back with me and I can let you know if we have something. But the methods are out there. They're just sporadically implemented. So they're available sporadically as a result.
And within PrEP-IT, I think, Nicole, correct me if I'm wrong, but I think we've actually pulled those numbers out of the key populations atlas and put them in the reference information for the target setting.
Yeah, so we relied on a variety of sources, and that was one of them. And also in other cases, we sometimes provided just estimates based on commonly used assumptions, like 1.5% of the male population for MSM. Again, we say that our default estimates aren't, you know, they're our best attempt, looking at it sort of globally and trying to drill down for 32 different countries that are in the tool. And we encourage countries to use the best available data. So we don't want them to think just because those defaults are in there that they have to use them, that they are supposed to use their best data, but we'd like to help to the extent that we can.
I'm wondering, Keith, do you want to say anything else about kind of the relationship between the UNAIDS tool and PrEP-IT? Did you have any additional comments on that?
Sorry, I had to take you off mute, or take me off mute. No, I think, you know, PrEP-IT is a more fully formed or has more features than what the UNAIDS tool is designed to do. It's really UNAIDS designed it for local program use, where local data were available, and we were going to worry about how to extrapolate it for a national estimate at some later date. And then I think PrEP-IT actually gets at that a little bit better. So I think, you know, it depends what data you have and what administrative area you're trying to work in. But I do think that these are two two tools that work somewhat in harmony or in an integrated fashion, in the sense that they're addressing slightly different needs, even though they might overlap somewhat too.
And Keith, when you say local, do you mean kind of at the district level, or what does that mean?
Because the way we've designed it, or if you're pulling out local, what we were thinking is whatever the catchment area for a biobehavioral survey was, that's what this applies to. So if your survey is in Santo Domingo, then the data are most valid for Santo Domingo. But you might figure out, you might say, well, Santo Domingo is similar to the rest of the country or not. And then you would make further estimates or further extrapolations based on what you think is similar. But we really set it up so the substantial risk calculations are based on locally derived data.
Thanks, Keith. I'm not seeing any additional questions coming in through the chat box. I wonder if any of the panelists want to make any additional comments before we move to the closing. All right, so maybe I'll pass it back to the hosts to wrap us up. Oh, sorry, there was one other comment that I forgot to make. We're making some small corrections to PrEP. We released it on September 24th, and as questions have come in, we've made a couple of minor modifications. So before you use PrEP, make sure you go to the site and download the latest version anytime you're going to use the tool, in case we've made some sort of update or correction. All right, now back to Martha or whoever was about to speak.
It's Martha. Thanks, Catherine. I just wanted to plug to everyone that we have all of the recordings from these webinars on PrEP Watch. In addition, we provide the slides, and we also provide a resource sheet which answers the most commonly asked questions by the participants during the webinar. So please do go and look back at past webinars, because so far we've covered quite a number of topics this year. I also wanted to plug for anyone that's going to be at ICASA. We're having a costing satellite session on Tuesday, December 3rd at 10:45 a.m. in Kigali. So if you are going to be at ICASA, please do attend the satellite session if you're free. I wanted to let everyone know that this is the last webinar that we're going to have in 2020, and then, in 2019, and then we'll pick up the webinars in January of 2020. And we've created a survey that we would really love for you guys to fill out, asking about what topics you'd like to see discussed during the webinars, how frequently you want to have the webinars, and any other feedback that you'd like to provide us. So Nina is going to put a link to a survey in the chat box. And we really do want to make these webinars responsive to the information that you want to hear and discuss. So Nina, why don't you, if you could go ahead and put that link in the chat. I would really ask that people fill that out, and we will take that into consideration, and we will send out more information about the upcoming webinars in early January.
Excellent. I just posted the link, so everybody should be able to complete that survey now. Please let us know if you can't see the link. Great. And I think we will end 10 minutes early to allow people time to fill out that survey and let us know what topics are of interest for 2020. So thank you to all of our panelists for their expertise today, and thanks for everybody joining.
Thanks, everyone.
Thank you.